So thank you for having me, everyone. The title of my talk is The Meaning of Words, and I hope to take us through a journey to understand the impact of the words we use in medical documentation and the potential impact it has on patient care. I have no disclosures and no conflict of interest. And my objectives for this talk are one, to explain the harmful impact of using negative patient descriptors in clinical documentation, and secondly, to describe strategies to promote patient-centered documentation among learners. Now, to understand where we are with clinical documentation, I think we have to take a look back in time to see what the purpose and the utility of progress notes are. And so I would take us back to between the 4th and 5th century BC, when Hippocrates and other physicians of this time compiled a book containing 70 medical scripts, which really was the first time that we found evidence containing medical documentation. These scripts had examples that resembled modern medical records, including accounts of patients, descriptions of encounters, recommendations, descriptions of procedures, and prescriptions for ailments. At that time, this book was really meant for only the eyes of other physicians. It was meant as a tool to pass along knowledge and for medical education. This tradition of encapsulating medical knowledge through records was continued through antiquity. 400 years later, the Roman and Greek physician Galen wrote and compiled histories of patients, again, to pass along medical knowledge from his medical encounters. In the Middle Ages, Maimonides did the same thing, keeping logs of his encounters with patients, but only for the purpose of preserving and passing along medical knowledge. It wasn't until the 20th century that medical documentation served roles other than acting as a repository for medical knowledge. And it was only in the early 1900s that the American College of Surgeons mandated that all surgeons register patients and that physicians keep what were called treatment diaries. This represented a time when we really started to see medical notes being used more consistently in the clinical care of patients. By the 1970s, the ICD codes were formed and notes became more important in billing and coding, now serving as tools to gauge the amount and intensity of work a physician performed and tie it to reimbursement. In current time, I would argue we're entering another phase of medical documentation, one in which the notes are beginning to serve another purpose, and that's for the patients. This movement was really jump-started by the digital age, which facilitated the access of medical records to patients. In the 1960s, Mayo in Rochester was really the first academic institution to use the electronic health record. Adoption at other sites were slow due to costs in technology, and for decades, patients still found it difficult to bypass the curtain of medical establishments. They were really only able to get their medical records through tort and through subpoenas. That changed in 1996 when the Federal Health Insurance Portability and Accountability Act, known as HIPAA, was passed and stipulated that patients must be able to see and get copies of their records and request amendments. So at this time, physicians and health organizations were allowed 30 days at the time of request. And this bill was enacted at a time when most health information still lived on paper. In 2009, when the HITECH Act was passed, only 10% of US physicians had electronic medical records. This act encouraged the adoption of e-health record systems and tied meaningful use to reimbursement. And by 2011, over 50% of US physicians and health organizations had made the leap to electronic health records. Now, finally, in 2016, the 21st Century Cures Act was enacted and now entering the compliance phase in 2021. In addition to having broad landmark aims in healthcare that included streamlining approval of novel drugs and medical devices and allocating money to medical research, it removed barriers that limited timely patient access to their own health information. It facilitated the pathway for patients to obtain medical records by mandating that physicians and healthcare organizations must provide medical records to patients at their request and without delay. The information blocking rules of the Cures Act delineated the particular notes that all patients should have access to. That includes progress notes, discharge summaries, consultation notes, HMPs, procedure notes, radiology notes, and pathology and lab notes. So what was the impact of allowing patients more facile access to their own health information? Well, for one, one study done by the 3 health organizations, Beth Israel Deaconess, the University of Washington, and Geisinger, looked at their experience with open notes. They sent almost over 130,000 surveys to patients who had at least one progress note in the EMR and asked them to review their experience reading their notes. They had about 29,000 responses. Now, the vast majority of patients indicated positive experiences in having access to their records, indicating that they felt more in control of their healthcare, that they used the notes to prepare for visits, for remembering their care plan, and felt like they could take their own, take care of their health in a better way. There were only a few risks that were associated with those notes. Very few people said that the notes were confusing, that they made them worried, or that there was concern for privacy. Now, interestingly, when they looked at the specific patient's characteristics, Black patients more than white patients felt that note reading was important to them, and older patients or patients over 45 compared to those in their 20s felt that having access and reading their notes were more important to them. Compared to English speakers, patients who spoke a different language at home reported that the notes were helpful to prepare for visits and make the most of visits. And similar was true for patients who had fewer years of education. However, the ability to read notes also revealed that what physicians wrote in the chart could be offensive to patients and possibly affect the patient-physician relationship. From the same cohort of patients who had access to open notes, another round of surveys was sent in 2017 asking the patients 2 questions. Have you ever felt offended by something you read in a note, or have you ever felt judged by something you read in the note? If the patients answered affirmatively, they were then prompted to answer what made them feel judged and offended in an open-ended fashion. And they had 30,000 responses. 11% of patients felt judged or somehow offended. And when the researchers looked back to see what categories of offense or what themes these fell into, there were really 3 main themes. To the left was disrespect, where patients felt like the tone of the writing was condescending, or that they did not feel heard or were misquoted. Clinical language or conventions such as patient denied or patient claims were also found to be unfavorable. Other themes included errors and surprises, where there were inaccuracies, when confidentiality was felt to be breached by the patient if they shared something that they didn't expect to be in the medical record. And then finally, labeling, when terms were used that the patients found either stigmatizing or offensive. And so to show how this unexpected event kind of happened when we share notes with patients, I'd like to share a clip from a series called Seinfeld that has many words of wisdoms from the past. So this will only be a minute.
In a moment. You should be reading that. But tell me about this rash of yours.
Well, it's You know, I noticed that someone wrote in my chart that I was difficult in January of 92. And I have to tell you, I remember that appointment exactly. You see, this nurse had asked me to put a gown on, but it was a mole on my shoulder. And actually, I'd specifically worn a tank top so that I wouldn't have to put a gown on. You know, they're made of paper.
Well, that's a long time ago. How about if I just erase it? Now, about that rash.
But it was in pen. You fake race.
All right, this doesn't look too serious. We should be fine.
What are you writing? Doctor?
Okay, so you could see from this clip that this was a time before open notes and the potential impact we have when we document in a way when patients have access to our writing. So we also see the impact on the patient's perception and also the physician's view of the patient when a word like difficult is used to describe them. So I'd like to take a second to just read this description of a patient, Mr. B. He's a 67-year-old patient with a history of alcoholic cirrhosis, hypertension, diabetes, and CHF who presented to the emergency department for shortness of breath. He reports non-compliance with his diuretics and admits to not adhering on a low-sodium diet. Of note, this is his third presentation this month to the ED. He's failed to show up with his primary care provider after discharge. So after reading this, take a second to just ask yourselves, what's your overall impression of this patient? Is he responsible? Does he take care of his health? How do you feel about taking care of him as a provider? And what would your initial approach be to his therapeutic plan? Is the answer to counsel him on the importance of medication and diet because he fails to understand it? Now, read this other description of Mr. B. He is 67 years old with a history of alcohol-associated cirrhosis, hypertension, diabetes, and CHF, who presents to the ED for shortness of breath. He reports difficulty taking his diuretic. He shares that it makes him urinate frequently, and he does not have easy access to bathroom during his working hours as a driver. He shares that he's been eating more takeout food the last week due to heavy workload. He has not been able to follow up with his primary care provider after his last discharge. Now ask yourself the same questions. What's your overall impression of Mr. B? Is he responsible and does he care about his health? How do you feel about taking care of him as a provider? And what would your approach be to his healthcare plan? Do you think he knows the importance of taking his medications? I highlighted a few words that may have added to the color in the first passage that could affect the patient in a negative light. Alcoholic, which may be laden with bias. Non-compliance and non-adherence, which may suggest to some readers that the patient is volitionally and irresponsibly avoiding the prescribed care plan. Admits and failed to follow up, which suggests that he did something wrong. So without ever meeting or seeing this patient, you can see how providers can start off with a negative impression of him. So what are the terms that are harmful that we frequently see in the chart? Words that may label a patient by their disease, such as cirrhotic, sickler, IV drug user. Words that suggest a patient is difficult or frustrating to engage with, such as angry or insistent on. And then words that connote that a patient isn't engaged in their own care and insinuate blame on their current illness, such as refuse, non-compliant, non-adherent, or resistant to. So think about how frequently you read these notes in the chart. And so just to think about a framework and definitions, I would propose kind of two things to think about that I'm going to use interchangeably during this talk. Stigmatizing language, which assigns negative labels, stereotypes, and negative judgment. And negative language, which doesn't necessarily have to be stigmatizing, but actively promotes an unfavorable view of the patient and doesn't serve to move the treatment of the patient forward. Another way to define harmful language is to think about broad categories and their effects on the patients. Mary Catherine Beach's group at the Johns Hopkins Hospital reviewed over 500 notes to look at linguistic themes in cases where there were negative impressions that were conveyed in the medical documentation. And they came up with a few ways that we can think about how these negative descriptions show up in the chart. One is questioning credibility. That implies physician disbelief of the patient's report of their own experience. For example, he insists the pain is behind the knee. He claims the nicotine patch doesn't work for him. Disapproval that highlights poor reasoning or decision-making in a way that conveys the patient is unreasonable. So she's adamant she can't perform any kind of exercise due to pain. Stereotyping that quotes incorrect grammar or unsophisticated terms and paints patient unfavorably. So reports she's unable to fulfill her prescription for the sugar pill. Difficult patient. This includes details of questionable clinical significance that depicts the patient as unreasonable or implies the physician's frustration. For example, he perseverated on the fact that a lot of things are going home at home with my family and quote, you wouldn't understand. And finally, unilateral decisions that use language to emphasize the physician's authority over the patient. That she was told to discontinue. I have instructed him to do X, Y, and Z. So how much do these words really matter? And can they affect attitude? Let's take the terms substance abuser versus a person with substance use disorder. So substance abuse may evoke perceptions of volitional and purposeful actions and not take into account environmental and genetic factors that lead to substance use. They also may imply that a person who's described is more blameworthy or less deserving of care and empathy. So one group took a research approach look at this. And in 2010, sent surveys out to recruited survey participants rather around the Massachusetts General Hospital campus. They recruited 300 participants and showed them a scenario where someone was described as having substance abuse and a substance use disorder, and another scenario in which they were described as a substance abuser. They were then asked questions in various domains about the person based on the description. The domains being if the patient deserved treatment, if the patient deserved punishment, if they were a social threat, for example, if they would be willing to have them as a neighbor or a coworker. For the domain of attribution blame, in which the problems that they were seen having were caused by stressful life circumstances or their own choices. Attribution exoneration, in which the issue or the problem had origins in environment, genetics, or self-regulation, in which it was perceived that they had control of their own actions. And what they found was that those who read the scenario in which the person was described as a substance abuser were felt to be less deserving of treatment, more deserving of punishment, had more attribution blame, less attribution exoneration, and were perceived as being able to more willingly self-regulate their own behavior without treatment. In short, they showed, in these short words, have a stigmatizing effect on patients. And this stigma can have profound effect on the patient's engagement in their own healthcare. One survey to 150 patients with cirrhosis asked them 18 questions related to if they were feeling any stigma. 90% of the respondents chose agree or strongly agree for at least one of the questions, indicating that they felt stigmatized in one arena of their life. And this stigma was associated with symptoms of depression, lower social support, decreased healthcare seeking, and worsened quality of life. What was really fascinating about this article was they included the words of the patients in the paper, and some of them were very profound. I believe people and even some friends prejudge me as drunk or a heavy drinker. When they first hear about my liver problems, you can see the prejudgment that I drink a lot and do not take care of myself. Before being diagnosed with Hep C, I was a productive public figure. I tried to hide my diagnosis. When my liver disease and Hep C leaked, I had a hard time with the stigma. I'm horribly embarrassed at having cirrhosis. And I feel pain involved is undertreated and not believed by medical personnel due to the thinking that I already have a substance abuse problem. So we discussed how language can affect provider attitudes and belief and potentially propagate stigma. This stigma also has implications on physician practice patterns and patient outcomes. In HIV patients who sense a high degree of stigma around their illness, consistent use of antiretroviral therapy is lower and follow-up is poor. Physician practice may change as well. In one study done by Mount Sinai's own Dr. Glassberg and Dr. Lynn Richardson, a survey was distributed to physicians attending the American College of Emergency Physicians annual meeting, where they asked if the doctors used the term sickler to describe patients with sickle cell disease. Those that use this label frequently or always had less positive attitudes towards patients with sickle cell disease. And interestingly, were also less likely to report adhering to best practice treatment guidelines for patients with sickle cell who are presenting with sickle cell pain. For example, the use of IV opiates, escalating doses for non-response, and the use of PCAs. Another study by Anna Gadu and Mary Catherine Beach at Hopkins randomized medical students and residents to reading a scenario regarding a 28-year-old patient with sickle cell disease who presented with a vaso-occlusive crisis. In one scenario, the patient was described as still having 10 out of 10 pain after the first dose of opiates. He was described as not tolerating his oxygen mask, and the therapy was described as opiates. In the other scenario, the patient was described as insisting pain is still a 10 out of 10, refusing his oxygen mask, and the medications were described as narcotics. The students and residents were then asked questions on attitudes of the patients, and then the residents were asked on the care. So using a scale called the positive attitude towards sickle cell patients, or the PASS scale, residents and med students who read the more stigmatizing language reported a lower attitudes or more negative attitudes towards the patients. Those who read the passage with neutral language reported more positive attitudes. So the residents were also asked about how they would control the pain if it didn't respond to opiates. Options included ketorolac, using oral opiates, or increasing intravenous opiates. And those residents who read stigmatizing language were less likely to use aggressive care in the management of these patients when reading passages with stigmatizing language. And so interestingly, just reading a passage with stigmatizing language can affect the way that physicians practice medicine. One interesting facet of the study is when they were asked to reflect on the notes, many respondents were able to identify potentially impactful language, even if earlier they had made their own judgments based on that language. And this really shows a capacity that reflection may be a possible intervention as we're thinking about how to educate people about stigmatizing language. So how often does stigmatizing language appear in the chart? One study at the University of Chicago looked at a cohort of 19,000 patients over 33,000 encounters. This comprised of inpatient, outpatient, emergency department. And they pulled words that were negative descriptors, for example, aggressive, agitated, angry, combative, and looked how frequently these appeared in the H&Ps. So refused appeared the most with 1,400, then non-adherent, non-compliant, and agitated. When they looked at the characteristics of the patients where these words were applied, what they found was that there was large racial disparities. The odds ratio of a Black patient having these terms applied to them in comparison to whites was 2.84. Same with Hispanic or Latino patients compared to whites. Patients who had Medicaid compared to private insurance or employer-based insurance also had a higher rate of these words applied to them. So given how unevenly these terms were applied, this suggests that stigma and bias may also be transmitted through the medical record. So now I've shown you that negative and stigmatizing language exists in the patient charts. And for physicians, they can potentially affect attitudes and beliefs and practice patterns. For patients, they can affect the patient-physician relationship and also affect stigma, thereby potentially impacting health outcomes. So what are some of the strategies we can utilize in order to change our behaviors? A big challenge people frequently cite is that they don't know alternatives that they would normally use to negative descriptors. And as we're learning to recalibrate the way we write and document, we can use lists with alternatives to rephrase harmful language. For example, instead of using substance abuse or addiction, to use substance use disorder. Instead of calling patients angry, aggressive, belligerent, or confrontational, explain the behavior that they voice concern or express frustration, or describe the observable behavior. Instead of exaggerate, use the patient words. Instead of describing them as non-compliant or non-adherent, saying that they were unable to or faced challenges to, and then describe the barriers. Similarly with uncooperative, to describe what could not be completed or tolerated. And instead of refuse or resist, use patient-centered words, including decline, defer, or disagree. So there are a lot of these words that we use in medical documentation as now convention, and may take times for learners to unlearn some of these words. Another tool is to use person-first or person-centered language. So a common convention is to shorten descriptions of patients to their disease. A cirrhotic, a diabetic, a COPDer. This reduces the identity of the patient down to their illness and frames their disease as the most important aspect of their being. It may make our biases and associations with those conditions more salient. Person-first language is a linguistic paradigm where we name the person first and then the condition. So instead of describing someone as a diabetic, we describe them as a person with diabetes. And the intention is to bring back the identity of the person as the most important and the disease as secondary. This was first championed by people with disabilities, but is now finding its way to many other conditions with stigma, like substance use disorder and mental health, and can be a powerful tool as we kind of recalibrate and reframe the way that we document. So when writing notes, another strategy would be to pretend that the patients are reading the note. They may likely be reading them. And so thinking back to the broad categories in which terms can be and language can be negative, think about the areas of where we're questioning patients' credibility. And instead of doing that, affirm what they're telling you. So instead of he insists, simply write he reports pain behind the knee. Avoid phrases and words that convey disapproval. So in circumstances where the treatment plan or the therapy requires patient engagement, consider how to reframe the sentence to explain the obstacle. For example, she was not able to take her antibiotic due to nausea. And be aware of stereotyping language. So instead of quoting language that casts the patient in a negative light, use accurate and precise language. For patients that we've traditionally labeled as difficult, we tend to add negative descriptors and details that aren't clinically relevant or not necessary to provide care. Avoid this pattern. Stating the simple facts and using neutral tones should be emphasized. So instead of he refused to listen to, we can simply state we were unable to discuss further. And finally, avoid unilateral decisions. Include shared decision-making language. For example, we discussed instead of I instructed him to. What about the encounters that don't go as well as we had planned, where there are disagreements with the path moving forward? How do we capture what was discussed in a way that doesn't do harm to the patient? I propose asking ourselves 3 questions. Does the documentation move the care plan forward? Meaning, do the details provided contribute to the next phase of clinical decision-making? So when we write that a patient refuses treatment, are we using language that conveys our own personal reaction to the discussion? Or should we be using language that's meant to let the next clinician know what tests and therapies have already been discussed and explored with the patient so that the next physician can formulate a more patient-centered care plan? Ask, how will the patient perceive the documentation? As I said previously, we can practice writing in the chart in a manner that's transparent. In times when our recommendations differ from the desires or values of the patient, demonstrating neutrality, or better yet, understanding of their values is one way to capture the encounter without casting them in a negative light. And finally, ask ourselves, how will the next reader perceive the documentation? So to help the next level provider best take care of the patient, the documentation should reflect objective clinical decision-making rather than shedding value judgments. When we write negatively on patients, their care is already at a disadvantage even before the next physician actually meets them. So how do we impart these lessons to our learners? There are standards around language that the ACGME promotes in the milestones for postgraduate education, ensuring that residents use language to demonstrate respect and establish rapport, that they use language that is effective in communicating even for challenging patient encounters, and that they identify complex barriers to effective communication, including personal bias, and that the communication should reflect shared decision-making. However, this guidance on language is not mentioned in the documentation part of the standards. And given how available medical records are to patients, similar standards of respectful language and surveilling bias should be applied in the documentation parts of the milestones. It's important to think about how we can teach effective documentation in the medical record for trainees to build good practices and take care of their patients. At academic institutions, particularly on inpatient services, they bear a great deal of responsibility for the documentations of the patients we care for. One other aspect that I would consider when thinking about how we educate trainees is not to forget to address the automated structures around our clinical documentation. Templates and dot phrases in the EMR may still have phrases like alcohol abuse in screening notes or in the social history, and smart phrases that are pre-populated should be looked over for language that propagates the use of these negative descriptors. Problem lists may be another area that may be populated with information and that casts patients in a negative light. Once populated, they can be reviewed by providers and imported into notes. Finally, once a word or phrase has made it into the chart, getting rid of it may be extremely hard or challenging due to the copious amount of copying. There's one study that was completed by the University of Pennsylvania that looked at 100 million progress notes with 33 billion characters. And they found that there was over 50% of the material that was copied. And so given the ubiquity of utilizing copy forward, negative descriptors can be magnified many times once written into the note just once. So certainly we can teach good practices by sharing talks and lectures, suggesting words to learners. Another tool at our disposal might be through the reflections of past actions. The word reflection in its Latin roots means to bend or to turn back. And in the context of education, the practice of reflection is to turn back on thought and on past actions or ideas and analyze them for further knowledge. A more rigorous definition might be that reflection is a metacognitive process that occurs before, during, or after situations to develop greater understanding of the self and situation so that future encounters of the situation are informed from those prior. So in the first phase, the learner has the experience. And the second phase, they recall the event and analyze what happened. And this leads to the third phase of conceptualization. This is a time when they make attempts to understand their actions or reactions to the experience. And in this phase, they start to identify what skills or what new information they need before facing a similar event in the future. And the fourth phase is applying this. And the largest pitfall and challenge for reflection is learner engagement. So it's important to plan the format of the reflection and to give learners preparation time ahead, of the reflection. Studies have shown that strategies including group-led discussions, the use of multimedia, and creative activities have had a positive effect in increasing engagement among this current crop of learners who've grown up in the internet age. And so with this, I would pose the question, can reflection decrease the use of negative descriptors in clinical documentation? In the final part of this talk, I'd like to describe our exploration here at Mount Sinai into a reflection exercise as part of a project that was generously funded by the Institute of Medical Education's Challenge Grant. So, and this self-reflection piece was in partnership of a larger curricular initiative led by two medicine pediatric residents, Adam Kraus and Luis Saya. First, we asked how prevalent is negative language in the chart here at Mount Sinai? And so negative language can be written in many different ways, from using words with negative connotations to describing clinically irrelevant details that cast patients in a negative light and propagate stereotypes or bias against the patient. But to simplify the measurement of negative language, we looked at descriptors that have been previously published in the literature, such as refuse, difficult, non-compliant, and resistant. And to understand its prevalence, we took just a moment in time in one of the medicine teams, the Silver team, which cares for patients with HIV and geriatric population. And in looking at one day with just 12 patients, 9 of these patients, or 75%, had a negative patient descriptor in their chart in that current admission. Now, these were contained over all notes, physician, resident, attending, RN. And in total, in these 12 patients, we found 78 negative descriptors in that current admission. Examples included non-compliant with antiretrovirals, refused to work with PT, patients non-compliant at times, and resisting the attempts of the nurse to change her bedding. And so knowing that these terms were used here on our own service, we looked towards a reflection piece to ask residents to look at their own documentation and their own patient panels to see how this might impact their care. So the exercise looked at PGY1 medicine residents as interns write notes most frequently on the inpatient service. The residents were given a list of patients that they cared for either on their inpatient panel, outpatient panel, or patients that had written progress notes for on their inpatient service. They were then asked to search for a list of negative descriptors, for example, non-compliant, in the EMR. For these patients, then they were asked to review the notes in which these negative terms appeared. And so every patient that appeared had at least one descriptor in the list that was given to the patient. They were then asked to reflect on what they read. And specific questions included asking themselves the context or the clinical situation the negative descriptor was used, if there was an opportunity to use alternative words, the potential impact of negative descriptors in clinical care, the potential impact on the patient's perception of their illness, and potential implicit bias in the use of the word. So then as part of our outcomes, we asked, what was the prevalence of the words of the negative descriptor words, and if they changed in our documentation on the internal medicine service after implementation. So in the baseline from July to September of 2022, we looked at 780 patients that were on the internal medicine inpatient service who were cared by PGY1 medicine residents and had documentation by them. We looked at 17 words that had previously been described in the literature. And what the baseline data showed was that the words actually appeared very infrequently. Addiction or addict only appeared 0 times. The word abuse only appeared 12 times. Angry only 6 times. The most frequent words were refuse, agitated, non-compliant, and non-adherent. And this was consistent in terms of how frequently those words were with the literature. So when we looked after the intervention in the springtime for a 3-month period, 594 patients were then reviewed and manually abstracted for those same 17 words. We found little difference between what happened after the reflection piece and the intervention from before for the individual words. One caveat is that the words appeared so infrequently so as to suggest that any differences within the individual words may not have been picked up given the sample size. When we looked at the aggregate number of words, so the total number of patients with at least one negative descriptor, there were 16% in the pre-intervention phase and 14% in the post-intervention phase. This did not reach statistical significance. The total number of residents using at least one negative descriptor was 91% pre and 84% post. We want to take a deeper dive into the word refuse. And what we found was for refuse, there were 51 patients in the pre-intervention phase in which the word refuse was used, 66 times in which this was typed uniquely. However, 216 times total that included copy forwarded, all to show that if a word made it into the chart, it was copy forwarded more than 3 times in the chart afterwards. And this may have affected the number of instances in which we found the descriptors in the post-intervention phase. Interestingly, there was no difference between men and women. There was no difference in terms of English language. And when we looked at race, the number of charts that had negative descriptors did not reach any statistical significance between non-Hispanic whites, non-Hispanic Black or African Americans, and Latin Americans. So when we reflected on some of the findings, what we can say is that reflection is one piece of the puzzle, but may not be enough. Overall, the incidence of negative patient descriptors is low in internal medicine notes. That reflection may still change learners' attitudes about stigmatizing language in the medical record. Although residents had similar rates of documentation with negative descriptors pre and post, their reported attitudes indicated that they were willing to change their behaviors and document differently. The other finding was that the frequent use of copy forwarding function among residents in note writing may contribute significantly to the incidence of negative language in the patient chart, and that future education shouldn't ignore strategies that address automated structural aspects of note writing that includes copy forwarding, templates, smart phrases, and problem lists. So I'd like to end with a moment of levity. And I know you're all wondering what happened to Elaine if she ever got her rash figured out. So in the last minute, I'm just going to show you.
Doctor? I can't believe what happened to me at the doctor's office today.
Not the gown again.
No, I was looking at my chart and it said that I was difficult. Why would they write that?
They've gotten to know you.
And then the doctor writes more stuff down there and he doesn't even look at my rash.
Why don't you find a doctor that doesn't know you difficult? See, Elaine, you really didn't have to put on the gown.
Oh, it's my pleasure. I love these. You know, in fact, I've got one at home. It's perfect when you just want to throw something on. Hi.
Alrighty. Let me just review your history before we begin.
Oh, where did you get my chart?
From your last doctor. Standard procedure.
You know, I can tell you my whole history. Let's just.
Okay, let's take a look. Well, that doesn't look too serious. You'll be fine.
Please, wait, it's really, really itchy.
So in ending, I'd like to acknowledge and thank the Institute of Medical Education for their support. Dr. Beth Raucher, the Vice Chairman of Quality and Patient Safety for the Department of Medicine and a perennial mentor for projects within the Department of Medicine. Dr. Adam Kraus and Louis Saia, Mace Mansour, Ellen DuPont, part of the QI team, and then our student reviewers, Michael Chang and Roshan Vasoya, who helped us review over 1,400 charts. So I will stop there, and I thank you for your time.